Hi everyone, I'm Dr. Asghar Mesbahi, a medical physicist, and I want to talk about a technical comparison between conventional fan beam computed tomography and Linac-based cone beam CT. Today we are going deep into the physics, geometry, and detector mechanics that separate these two imaging modalities. I think understanding these differences is vital for optimal image-guided radiation therapy and artifact mitigation. Let's start with the fundamental geometric configuration. Conventional diagnostic CT utilizes a fan beam geometry. Here you can see in figure A, the fan angle is a transverse plane, is wide to encompass the patient's lateral dimensions, but it is strictly collimated in the longitudinal or z-axis. Linac-based CBCT completely changes this paradigm. It features a cone beam geometry where the cone angle is significantly expanded in the longitudinal direction. And instead of imaging a single slice at a time, the cone beam encompasses an entire three-dimensional volume in a single gantry rotation. Figure A shows a more accurate depiction of the modern multi-slice CT scanner, where the fan angle defines the fan beam geometry, but there is a non-negligible X-ray beam divergence in the orthogonal direction. For typical 62 detector array CT scanners, the fan angle is approximately 60 degrees, while the cone angle is about 2.4 degrees. Now we are going to talk about the CBCT system on the Linac. Radiotherapy-based CBCT scanners make use of a flat panel detectors for the detector array. As shown in figure A, this setup uses a fold cone beam. I have shown the location of the flat panel detector on the Linac here. Here the cone angle is almost as large as the fan angle. Because we use a flat panel detector instead of the curved one, the distance from X-ray source to each detector element is different. These different distances change the beam intensity across the panel due to the inverse square law and the heel effect. So we need correction methods to fix these effects in final CBCT image. Now we are going to talk about the detector architecture in both modalities. In this section, I'm going to talk about the conventional CT. The physical shape and architecture of the detectors dictates how high energy photons are collected. In this conventional CT, we utilize highly optimized curved array of the discrete solid state scintillator. As you can see here in the upper image, these are physically isolated from one another to prevent crosstalk and are curved precisely around the focal spot to maintain a constant source to detector distance. For the detectors, we use high density solid state materials like ceramic gadolinium oxysulfide paired with the photodiodes. These are designed in a curved arc-shaped array with multiple rows. Finally, the readout rate is extremely fast, operating in kilohertz range. This ultra-fast reading allows the system to capture thousands of images per second, which completely stops motion on sharpness or blur. When X-ray photons hits the scintillator, as you can see in the figure here, they are converted into light photons. These light photons then strike a photodiode made of silicon, which transforms the light into an electrical signal used for the image formation. When the light heats the photodiodes, its energy frees electrons inside the silicon. This movement of the electrons creates an electrical current which the computer reads to form the final image. When we talk about the Linac CBCT systems, it is a little bit different, or maybe there is a significant difference in some cases. Linac CBCT systems rely on flat panel detectors, originally adapted for digital radiography. In here you can see the image detector and elements who forms the whole detector. These panels use an amorphous silicon thin film transistor array, which coated with the thallium-doped cesium iodide scintillator layer. The flat geometry introduces variable photon incidence angle across the panel, and the readout rate are restricted to 30 to 60 frame rates, which are significantly lower than the kilohertz sampling rate seen in the diagnostic units. In figure A, we can see the structure of entire detector, which is made up of individual detector elements called the deck cells. Each deck cell contains a sensitive light detecting area as well as its own control electronics. In here, you can see that it is the electronics, and this part is the sensitive area for X-ray detection. Because electronics take up space, a portion of the detector surface cannot capture X-rays. This inactive space reduces our geometric efficiency, which is the ratio of the active sensing area to the total detector area. Let's look at the figure B here. It shows indirect systems where X-ray photons are not directly transformed to electrical signal, and they do it through light photons. Light photons in the indirect system propagate laterally, as you can see here, compromising resolution. The detected signal shown for the indirect detector shows this lateral spread in the signal from one X-ray photon interactions. If we have one X-ray photons here and one interactions, in the detection part, we can see that 1, 2, 3, 5 detector elements are receiving the signal. So 1 point shows itself as a 5 point. It is some sort of spatial resolution degradation. The other important differences between two systems is the quantum detection efficiency of the detectors. Now we should define quantum detection efficiency first, and then we go to define the differences and explain the main differences between two systems. Let's look at the slide here. According to the definition of the QDE, QDE measures detector efficiency at converting incident X-ray photons into a usable signal. As you can see here, QDE is the ratio of the detected signal to the number of the incident photons. In here, for example, we have 4 photons, and from 4 photons, only we detected 2 of them. Here, 1 couldn't be detected, and the other one is reflected. So we have two detections here. So QDE will be 50%. In conventional CT detector, we have exceptional QD. It is around 90%. Because detector is divided into discrete channels, the scintillator crystals can be made very thick to absorb almost all incident photons without causing blur. Conversely, a CBCT flat panel requires a thin scintillator layer to keep the light from spreading laterally and blurring the image. So, thin layer sacrifices photon absorption, dropping the QDE down to around 40 to 60%. This means that for the exact same number of photons hitting the detector, a CBCT panel produces more quantum noise, requiring a higher relative dose to achieve acceptable signal-to-noise ratio. It reflects the probability of that a photon will interact with the detector material rather than passing through. Now let's address the single biggest critical challenges in cone beam CT imaging. It is photon scattering. In conventional CT, the thin fan beam collimation restricts the volume of irradiated tissue. Scattered photons simply miss the narrow detector array, resulting in a scatter to primary ratio of less than 20%. So, what is this PR, or scatter to primary ratio? The amount of scatter detected in an image is characterized by the scatter to primary ratio, or scatter fraction. The figure shows the primary and scattered photons received by a flat panel detector in CBCT. As you can see here, we have three photons, and all of them are detected, but you can see that we have two of them scattered, and only we have one of them that not scattered and as a primary photon is detected. This PR defined by the amount of energy deposited in a specific location in a detector by scattered photons divided by the amount of energy deposited by primary photons. In CBCT, the wide cone angle illuminates a massive volume of the tissue simultaneously. So this triggers widespread Compton scattering events. These scattered photons travel in all directions and strike the large flat panel detector alongside the primary photons. For example, in pelvic imaging, the scatter to primary ratio can exceed 4. It means that 400%, meaning that there is 4 times more noise and scatter photons hitting your detector than the actual primary beams coming from anatomical signal. What are the clinical and physical consequences of this high scatter to primary ratio? To better understand this concept, compare the two head scans on this slide here. On the left, a fan beam CT simulator image, and on the right is the cone beam CT from radiotherapy image. As you can see clearly, there is a differentiation in the quality between two images. The highest PR severely degrades soft tissue contrast, as you can see on the CBCT images, and washing out the boundaries between organs at risk and targets. Second, it causes severe CT number inaccuracy. classically presenting as a copying artifact. We will talk about it in the next slide. In the copying artifact, the uniform anatomy appears falsely less dense in the center. Because the Huntsville units are distorted, physicists cannot reliably use raw CBCT images for direct pixel by pixel dose calculations, which can be useful in adaptive radiotherapy. So we need to do lots of corrections before using it for adaptive radiotherapy. Now we are going to talk about copying artifact. It is another problem of CBCT. As you can see in figure A, it is the upper image. The appearance of the copying artifact can be seen on these images, and you can see the profiles. It shows the CT numbers from going from here to here. As you can see, the CT number goes down here, but in the CBCT image, which copying artifact has been removed, you can see we have uniform CT number. Yeah, we have some noises, but the CT number is the same. Let's compare the two head scans in figure B. On the left is the CBCT image with copying artifact, and on the right is cone beam CT after artifact removal. You can notice the difference between two images in central part of the skull. Here, you can see that we know that it is soft tissue, but it shows itself as air, as a low density material. After artifact removal, you can see that it is uniform density material. Copying artifact causes darker points and lower CT number in the central part. It is the thing that you can see on the images. The artificial drop in Huntsville units toward the center of the uniform tissue is primarily driven by a high scatter to primary ratio. Because the broad cone beam creates massive scatter across the detector, it can mislead the system into underestimating tissue density. Now it is time to talk about timing. CBCT image acquisition time is significantly higher than the fan beam CT diagnostic CT. So the parameter here is the temporal resolution. And it is another major point of the divergence between conventional and CBCT. CBCT of radiotherapy, I mean. A diagnostic CT gantry spins at incredible speed, completing a full rotation in a fraction of a second. It means a half a second, or maybe 20% of the second. But in a Linac, however, we have something between 30 to 60 seconds for one rotation. Why? Because one Linac gantry weighs several tons because it houses a complex linear accelerator, bending magnets, and heavy multi-leaf collimator. So for mechanical safety and structural integrity, these gantry take anywhere from 30 to 60 seconds to complete a single rotation. This long acquisition window introduces a serious challenges. The patient continue to breathe, their heart beats, and peristalsis occurs during entire scan. So CBCT are more susceptible for motion artifact compared to the conventional CT. Now we can summarize whole talk in this slide. First, Geometry matters. While wide cone angle allows us to capture 3D volumetric images in a single sweep, they bring along significant scatter challenges. Second, detector physics directly dictates image quality. Flat panel detectors generally have a lower quantum detection efficiency, which means we have to rely on advanced image processing to strike the right balance between image noise and patient dose. Ultimately, understanding these underlying mechanisms empowers RTTs to optimize daily scanning protocols while enabling medical physicists to implement precise adaptive radiotherapy workflows. So, finally, what are your thoughts or experience with these trade-offs in your clinic? Drop your comments down below and let's get the conversation started. Thank you for watching this video. For now, bye.